Alright, let me start this quiz on eyelid and orbit. Alright, the first question is regarding proptosis. Proptosis means protrusion of the eyeball, and the non-axial means the eyeball is not coming in the center, it is coming in a particular direction. And a 50-year-old patient with bulging eyes, non-axial proptosis, which is not the cause. So, lacrimal gland tumor is located supratemporal, it will cause down and medial proptosis classically, that is causing non-axial. Any sinus tumor will push the eyeball in particular direction. A frontal mucosal will push the eyeball down. Now, optic nerve meningioma is just behind the eyeball, that is retrobulbar. It will push the eyeball in the center, that is causing axial proptosis. And lacrimal sac is present in supromedial, it will cause down and out proptosis. So, answer is straight away optic nerve meningioma is not a cause of non-axial proptosis. Now, second question is a patient after road traffic accident comes to you on examination. Right eye was protruding in out in out in out. That is pulsatile proptosis. So even if you don't know anything about this, in out means it is pulsatile proptosis, not intermittent proptosis. And there were limited eye movements, auscultation over the bruit. The doctor can hear some sound that is bruit positive, and that is seen in keratico cavernous fistula. That is an example of cavernous sinus syndrome. If cavernous sinus is involved, the patient can have proptosis, and if there is a fistula between internal carotid artery and cavernous sinus, there is a pulsatile proptosis. The patient has whooshing sound in the head that can be heard by orbital bruit by the doctor. There can be third nerve, fourth nerve, sixth nerve involvement, ophthalmoplegia. Other eye can also be involved, and other eye because there is an intercommunication with the cavernous sinus. And IOP is high because it will raise axial venous pressure. That is true. But even if you don't know this, you should know it is not a cause of intermittent. Intermittent proptosis is sometime eyeballs coming out, sometimes not coming out. That is seen a classical example, orbital varices. A young male coming with intermittent proptosis on bending, cuffing valsalva. That is orbital varices. That is example of intermittent proptosis. Now, straight away question: most common benign intraorbital tumor in adults. If it is a child, then the answer is dermoid cyst. If it is adult, it is cavernous hemangioma, most common in females. Retrobulbar tumor causing pushing the eyeball out, that is axial proptosis, and it's a benign tumor, so resection is done. In total, resection is done. I know many people must have answered thyroid eye disease. That is the most common cause of unilateral bilateral proptosis. Okay, not a tumor. Now, painful proptosis is not seen in dermoid. Actually, it can be seen in dermoid if it ruptures, but that is not given. Retinoblastoma can have any presentation, can be painful proptosis, can be asymptomatic. Most common is leukocoria. Rhabdomyosarcoma is the most common malignant intraorbital tumor in child. Orbital cellulitis can have pain, of course, because there is infection, inflammation. So dermoid, most common location in orbit is supratemporal. Most common location in the limbus is inferotemporal. Dermoid. That is, and it causes. There is a picture also of dermoid. I asked previously also. It is a choristoma. That is a normal tissue in abnormal place. Dermolipoma is same as dermoid, but the location is in the fornix, and that has more of fat, yellow color in the fornix. That picture should not be asked. Dermoid picture of limbus dermoid. It was a repeat question also. So here the answer is dermoid. Okay. Now image question. Lateral view of the upper eyelid is shown. A structure is the orbital septum, and that is important in determining preseptal versus postseptal cellulitis. That is the answer of this question. B is orbicularis muscle. C is a levator muscle, aponeurosis, that is tendon. E is a LPS muscle, belly. D is a molar muscle. So which muscle plays an important role? Preseptal versus postseptal, that is orbital septum. That is A is the answer of this question. Because first stage is preseptal cellulitis, second stage is orbital cellulitis. And how do you differentiate preseptal from postseptal? There is a question based on that also. Now, this is a Navziger's view. When the patient is, when the doctor is looking from the head end view, right eye is having proptosis. This is worm eye view. Worm eye, when the doctor is sitting on the foot end, left eye is having proptosis. This is Hertel's exophthalmometer. All the three are for proptosis, exophthalmos, but D is a regurgitation test. And that is not, this was previously 55 years by mistake, it is 55 years. Of course it has to be 55 years, which is not useful in the patient and this is looking like a thyroid eye disease. Even if the normal euthyroid levels, thyroid eye disease can occur. Extraocular muscle enlargement, edema of the eyelid, bulging eyes. So D option is of no use in proptosis. Even if you don't know this question, the text, you should know the rule out. The three are for proptosis. This is for regurgitation test. That is for chronic dacryocystitis. In acute, you can't do because there is a pain, redness, swelling in acute, so you can't touch acute dacryocystitis like this. This is the Hertel's exophthalmometer. Can be used in thyroid. Can be used in blowout fracture. Why? Even if enophthalmos, eye is going inside, then also you can tell the difference. It can tell about proptosis as well as enophthalmos. But myasthenia gravis has no pain, no proptosis, no pulsations. That is of no use of exophthalmometer in myasthenia gravis. Most common eye manifestation in myasthenia is ptosis, increasing on as the day progresses. That's why patient, as the day progresses, more ptosis in the evening, and there is a tensilon test, ice pack test. When the ptosis improves, that is myasthenia gravis. Okay, so this image is also very important. This is a previous year question. In the CT scan in the left, see, it is a localized one. This is the abscess. Even if you don't know, this orbital cellitis has to be diffuse involvement. And why this patient is having sinusitis? Yes, every option has sinusitis. Why not only sinusitis? Because eye is also involved. Why not pre-orbital cellitis? Because if the orbital septum is breached, the infection is going into the orbit. Proptosis can occur, vision involvement can occur because of optic nerve compression, or limitation of eye movements because of muscle nerves involvement. If any of these three comes, it is not preseptal cellitis, because in preseptal there is pain, redness, swelling only in the eyelids. Then the third stage can be subperiosteal abscess, intraorbital abscess, fourth stage, and then cavernous sinus involvement. Now this picture, this scenario can be in subperiosteal abscess also, but and orbital cellitis also. But see the images of the abscess, not of orbital cellitis. Orbital cellitis will be a diffuse involvement that is very rare to be asked. So the image goes in favor of subperiosteal abscess. The text can be both cellulitis versus abscess. And RAPD means relative afferent pupillary defect positive, that is seen in optic nerve compression, Marcus gun pupil. Now this also MRI in the right, I hope you know MRI, right axial view, seeing from the foot end. This is retrobulbar tumor, this is optic nerve tumor. Only by this is very difficult at your level, but you should have to look into this. 5-year-old girl with capillary spots, not crackling, freckling please, with mild proptosis, that is optic nerve glioma. RAPT positive means optic nerve is maybe compressed, and that is seen in glioma. Why not meningioma? Because meningioma has a tubular appearance, and in meningioma the age is not 5 years. Age is about middle-aged females. So age also sometimes very important in telling about the optic nerve tumors. Why this is not optic neuritis? Because in optic neuritis there is no capillary spots associated. There can be RAPT positive, but there is no proptosis in optic neuritis. Surgical removal of the entire eyeball leaving behind the eyelid and muscles, that is enucleation. Evisceration is scraping the intraocular contents out, leaving behind sclera, optic nerve and orbit. Exentration is taking out everything in the orbit, leave up till the periosteum, that is exentration. So evisceration quickly can be done in bleeding anterocephaloma, suprachoroidal hemorrhage, that is painful blind eye, suprachoroidal hemorrhage, bleeding anterocephaloma, and panophthalmitis when it is not controlled by systemic antibiotics. Enucleation is done for intraocular tumors like retinoblastoma group E, group 1E, group stage 2, stage 1E, stage 2 retinoblastoma, can be done for choroidal melanomas, intraocular tumors. In intraocular tumors, evisceration is contraindicated. And excitation is done for intraorbital extension of the tumors, like retinoblastoma stage 3, or orbital cellulitis not responding to medical management, like mucormycosis. Then everything in the orbit is taken out, leaving behind up till the periosteum, that is exentration. I think and dacryocystitis is taking out the lacrimal sac, that is done in lacrimal sac tumors, or when the lacrimal sac is fibrosed, like shrunken lacrimal sac, like TB, sarcoid, leprosy, syphilis, and so on. Okay, that's the 10 questions. I hope you have done well. Best wishes.